Hi, everyone. My name is Avery Conkin. I'm a fourth-year medical student at Quillen College of Medicine in Johnson City, Tennessee. I'm currently going through the application process for internal medicine residency. Some of my interests are critical care and cardiology. So I wanted to present this case today on infective endocarditis after ablation for postoperative AFib following a CABG procedure and an aortic valve replacement. So I'll pull up my PowerPoint here. Here's the main slide here. So I kind of just wanted to focus on the management of postoperative AFib using both pharmacological and surgical intervention. So postoperative AFib affects nearly 40% of patients after CABG procedures, and treatment guidelines aren't well studied after failing first-line rate control with beta blockers. Our patient is a 73-year-old female with a past medical history of aortic stenosis, triple vessel coronary artery disease, type 2 diabetes, hypertension, who underwent a CABG procedure and bioprosthetic aortic valve replacement. Post-operatively, she developed persistent AFib that was treated with sotalol for 2 weeks. However, her AFib persisted and led to a decision to pursue ablation. 5 days post-ablation, she developed progressive weakness, low-grade fevers, elevated white counts, and a new onset first-degree AV block. The TEE revealed a new vegetative mass on the prosthetic valve, an aortic root abscess, and a mass on the tricuspid valve. Doppler imaging showed a shunt across the atrial septum at the site of the ablation procedure, and blood cultures ended up growing methicillin-resistant staph epi in 2 out of 2 bottles. So she was started on vancomycin, but the patient's condition continued to deteriorate, and she was then transferred to a higher level of care. She received a ventricular pacemaker, and however, despite aggressive treatment, she continued to decline and opted for comfort care. The echo images are shown here on this next slide. So figure 1 shows a 1.5 by 6 or 0.6 centimeter vegetation on the posterior leaflet of the tricuspid valve. Figure 2 shows your aortic root abscess here. And figure 3 shows the atrial shunt with left to right flow. So I also wanted to discuss ablation technique quickly for those not familiar. There's a little diagram shown here, but it's typically done through the femoral vein and advanced up the IVC to the right atrium, where the atrial septum is then punctured and giving you access to the left atrium. A mapping catheter is then used to identify the source of the arrhythmia, and a site is then ablated using radiofrequency energy. There's a large array of indications for ablation, but most common is failure of pharmacological management. So with this case report, I kind of just wanted to walk through the management strategies of postoperative AFib and persistent AFib. So, and just kind of highlight the complications that can occur with surgical intervention as well. So initially for postoperative AFib, the American Heart Association recommends beta blockers for rate control, and then the use of cardioversion and antiarrhythmics if beta blockers fail. So our patient initially received beta blockers and then sotalol for 2 weeks. However, after those 2 weeks, she was still having the symptomatic AFib, so the cardiology team, in discussion with the patient, decided to move down the persistent AFib ladder to ablation. And this is the ladder I'm referencing here. So this is from the European Society of Cardiology and their recommendations for persistent AFib. They have different recommendations for paroxysmal AFib as well. So starting with rate control, then moving down to rhythm control using antiarrhythmic drugs. In our patient here with valvular heart disease, we see sotalol here as a class 2B recommendation, which again, she failed, had recurrence of symptoms, shared decision-making with the patient, then led to triablation, which is a class 1 recommendation. However, the problems kind of begin with the time frame discussions and this patient being post-op from a major surgery and a CABG and valve replacement. And then having to receive another surgical intervention using the catheter ablation. So this next slide kind of highlights some of the complications we see with ablation, including esophageal fistula, thromboembolic events, cardiac tamponade, pulmonic vein stenosis, arrhythmias, and death. So these complication rates are relatively low and are associated with significant risk factors seen here. These risk factors include atrial dilation, older age, being a female, or using radiofrequency ablation versus cryotherapy. So endocarditis isn't listed as a normal complication for ablation. It was likely seeded from our aortic valve replacement procedure, which then traveled from the left side of the heart to the right side of the heart, and seeded the tricuspid valve only after the creation of the atrial shunt during the catheter ablation. So endocarditis with aortic valve replacement occurs in about 1.58% with surgical repair versus and a 51.85% mortality versus a 1.01% in transcatheter repair with about a 27.3% mortality. And it's also usually associated with coagulase negative staphylococci. Here we see early valve replacement and we see those coagulase negative. We also have Staph aureus and aerobic gram-negative bacilli. One final thing, a suggestion for future study direction could be focusing on optimal time frame intervals for balancing both post-op complications and symptomatic AFib. So thank you for taking the time to listen to my presentation, and I hope you were able to learn something from this presentation. Thank you.